Good afternoon, everybody. So I'm not Mario Santos. Unfortunately, he's got a flu and is not here. I'm a pulmonologist and also a sleep medicine specialist. So I'm basically a clinician. I'm very delighted to present this early career panel. And the first one is João Malato. I've noticed that the panel is quite different. So we have from both sides of the Atlantic. So exercise biologist. We also have a medical doctor from here from Porto, and we have also a biologist from South Africa. So we got a very interesting group of people here. So without further delay, I present João Malato, who is a computational biologist from Lisbon. He's working in Gulbenkian Institute for Molecular Medicine. So João will talk about why ME-CFS research is statistically challenging. Thank you, João.
Okay, so sorry, let me just set everything up. Okay. Hopefully, so is it sharing? Okay, so thank you for introducing me. Thank you to the organizing committee, and thank you to Joan for inviting me and allowing me to speak. So hi, I'm João. I'm a researcher here in Portugal, and I work with ME-CFS and long COVID, but I'm a biostatistician. So I'm going to present my side of the story a little bit more detached from the actual working with the patient. So it's more on a not meta-analytic side, but keep in mind that this is my perspective. Is it working? Okay. So I'm going to speak about how doing research in ME-CFS is a statistical challenge. So we all know that ME-CFS is a complex disease, and this is due to the absence of candidate biomarkers to objectively identify the disease, leaving clinicians to having to perform their diagnosis through, as Louise mentioned, symptom-based assessment criteria, physical exams, case history, and excluding for any other conditions that might result in similar symptoms. And the figure that I'm showing is that there are multiple unique, I'm sorry, this is just shifting. There are multiple unique symptom-based criteria to diagnose ME-CFS, which is the same as saying that there are unique case or unique definitions for this same disease. And this creates a challenge when we try to replicate other studies and replicate the results from other researchers. And I first experienced this and got ideas on this impact of how impactful this is in the replicability of ME-CFS research when I worked with Eliana and Luis at analyzing their UK ME-CFS biobank data, where we try to define the, sorry, this is actually, so we try to compare the profile of severity of different symptoms ranging from absent to mild, moderate, and severe, and compare it, this profile of severity between ME-CFS patients, healthy controls, and chronic fatigue, but not chronic fatigue syndrome diagnosed patients. And our results are plotted here in a multidimensional scaling plot. And we found out that we were able to discern in between healthy controls and ME-CFS patients, where healthy controls usually have less severe or a majority of absence of symptoms, sorry, and where ME-CFS individuals usually have more exacerbated symptoms. But when we try to compare and differentiate between patients that do have and experience symptoms and ME-CFS individuals, we see that there's a very wide overlap between them. And given that ME-CFS is symptom-based, that the diagnosis of ME-CFS is symptom-based, this might lead to this, well, got me thinking that there might be an impact of in research when we actually diagnose individuals that are not ME/CFS as being ME/CFS and include them into the cohorts for the studies. So we now enter into the hypothetical and more theoretical ideas. So if we think about a typical case control association study, we usually want to investigate the association between a candidate causal risk factor and ME/CFS. So to do that, we identify and diagnosed a group of ME/CFS individuals and find a sample of healthy controls matched for any potential confounding factors. So we screen these two populations for the presence or absence of a risk factor, and if it shows, sorry. No, yeah, so we screen the two populations and we compare the results for this presence or absence of a risk factor. And if we manage to reject the hypothesis that these two populations are the same, we get to infer on the link between a causal risk factor and the disease. But under the hypothesis of misdiagnosis, we assume that this diagnosed ME/CFS population is actually a mix between true ME/CFS individuals and apparent ME/CFS patients that essentially act as a diluting factor towards us finding this true association between a risk factor and the disease. And the more apparent cases we have, the less power we have to identify this true association and link any candidate genetic biomarker or exposure to any virus and the disease. So we did a simulation study where we sampled ME/CFS individuals and healthy controls and assumed that these false positives or these apparent ME/CFS individuals were in fact shared this risk factor probability as the healthy controls. So the more false positive individuals we had, essentially, the more diluted the true results would be. And so we, just to be very quickly, we played around with multiple parameters, such as the sample size of the studies, how strong the association between finding a risk factor and diagnosing the disease was, and how prevalent it was amongst the populations. And our result is show that if we have an ideal study scenario where we have more than 1,000 individuals per cohort, and we have a very strong association that is present in, it's an easy to identify. So the probability of rejecting, so how consistent a study is at finding this association doesn't really matter on how misdiagnosed individuals are. So if we have a misdiagnosis of 0, we are comparing only ME/CFS individuals versus healthy controls. And if we go all the other sides to the other side of the spectrum, we are comparing only apparent ME/CFS individuals, so false positives, versus healthy controls. And under a perfect and ideal, well-funded scenario, we could have even more than 80% of the population being misdiagnosed, and we could still find this to be statistically significant. Sorry, I'm just going to try and change this. Yeah, I'm just about to. So sorry. Maybe it will work this way. Okay, so, but this is not real-life ME/CFS research. So usually, for instance, we work with smaller sample sizes and associations that we try to go for and research are not that strong. So it's not a monogenic disease. It's something that it's much more nuanced. So we need to decrease the effectiveness of, or the strength of the association between finding a risk factor and actually being diagnosed with ME/CFS. And this further reduces our ability to detect the association. And since we are talking about a disease that only affects up to 1% of the population, and we have to look at specific markers for either autoimmunity or infection, which tend to be reduced in within the populations. So under the assumption of misdiagnosis, we can see that even in a perfect scenario where we are comparing healthy individuals against only true ME/CFS individuals, and we do replicate multiple studies, we would still get about only 50% of the studies. We will manage to find this true association, while the other 50% would not find this association. And you can see how conflicting this eventually becomes. And just my take-home message is that under this assumption that there's a misdiagnosis and inclusion of false positives or individuals that are being diagnosed as ME/CFS but are not in fact true ME/CFS, ME/CFS research has a suboptimal power, and we need to compensate for this by increasing sample sizes, implementing standardized case definitions or more restrictive ones, as Luis mentioned, and we should focus on more specific pathological mechanisms for the disease. And the silver lining here is that if we account for this, we can in fact significantly reduce misdiagnosis, but it takes a collective effort. And this is why these conferences are so important, because we get to share as much information, learn as much as possible, and eventually share data amongst ourselves to do multicentric research. And thank you.
Thank you, João. We will take the question in the end. So it's my pleasure to introduce Johanna Squires, which is an exercise physiologist who will speak about investigating ME/CFS and long COVID through iCPET. Okay, go ahead.
Nice. All right. Good afternoon, everyone. My name is Johanna Squires. I work at Mass General Brigham in Boston. And today I'm going to talk about our invasive CPET testing and autonomic function testing in ME/CFS and long COVID. Very quickly about me, my PI is Dr. David Sistrom, but I also work with Dr. Aaron Waxman, who's in the crowd, and my background is biomedical science and exercise physiology. To the patients out there, I promise I'm not going to tell you you have to exercise. I try and say that with every presentation. To start off, due just to time restraints, I'm not going to go into the grittiness of the iCPET. Dr. Sistrom, Dr. Waxman, Dr. Oliveira are going to talk tomorrow, and for the non-invasive one, Dr. Keller and Dr. Winck are speaking tomorrow. Just a very brief overview. A lot of you might be familiar with just the normal non-invasive CPET. What we do at the Brigham is we put catheters in. So we put one through your pulmonary artery and one in your wrist to get your arterial line. And what that permits us is not just oxygen uptake or oxygen utilization, but it also lets us look at pressures within your heart. It also lets us do arterial and venous oxygen content differences. So it's a pretty exciting test that we do quite frequently. So how can we use that in ME/CFS and long COVID? This is currently being written up as it is, but we wanted to compare the three, and we have a pretty good size. So we have about 1,600 people that have had an invasive CPET between 2019 and 2025. And then out of them, about 477 met ME/CFS IOM criteria. So my team doesn't just look at ICD codes. We go through all 477 people and do a complete chart review. For long COVID, we are doing IOM criteria as well, but following a confirmed COVID-19 infection. And for the controls, I take out every comorbidity known with ME/CFS and long COVID, so small fiber neuropathy, mast cell activation, Ehlers-Danlos syndrome, also taking out pulmonary hypertension, heart failure, the many other reasons why people get referred for invasive CPETs to get a symptomatic control group. And what we see here is that between ME/CFS and long COVID, there is no significant difference, but compared to those controls, it is significantly different for many of the major variables. And in particular, I want to draw your attention to peak right atrial pressure. That's where I'm going to be taking this presentation today. And peak right atrial pressure has been previously written about by Dr. Will Oldham, who also was working with us at the Brigham in 2015. And what he found was there's this phenomenon of preload failure or low filling pressures in the right atrium, less than 6.5 millimeters of mercury. And then in 2021, Dr. Philip Joseph took this and applied it to ME/CFS and controls and saw that there was almost 100% of preload failure in ME/CFS. Now, when preload failure pops up on the test, Dr. Systrom, this is a screenshot of one of his interpretations, will point out that the root cause appears to be preload insufficiency, as the right atrial pressures are essentially unmeasurable throughout upright cycling exercise. It eventually goes to long COVID-related dysautonomia. So that's where I'm going to take this, and that obviously with dysautonomia, be great to get a positive skin biopsy to adjudicate. So autonomic function testing is not just skin biopsies. It can be made up of the following. It can be a combination of the following. So you have electrochemical skin conductance, or ESC, quantitative pseudomotor axon reflex test, or QSART, both of which are looking at sweat production. You have tilt table testing. So I know patients will be very familiar with POTS and how it's a tilt table test or the NASA lean test of being diagnostic for that. And then you got skin biopsy. So the very common one being an epidermal skin punch biopsy, but there's also sweat gland biopsies. So what I wanted to do is kind of gather all of that, potentially also with epidermal. We know it's patchy. With sweat glands, we know they're deeper. So I wanted to take all of that and just kind of see where that leaves us. So this has been previously looked at by a group in Spain in 2023. And so I wanted to take our number. So that previous group of 477 ME/CFS patients, of that 477, 420 of them have also had autonomic function testing, which is not a bad group of them. And with long COVID, of the 93, it's 59. So I wanted to focus in on them. Now, before we move on to the small fiber neuropathy aspect of this and dysautonomia, I do want to just point out with that tilt table test, it did catch 31% in ME/CFS, which is sometimes higher than what other groups find. So we'll see going into that. But I wanted to focus on the small fiber, and there's a reason, and that's going into my next one. So with these colors, the darker pink is negative. So for small fiber neuropathy and ME/CFS, it's 36% negative. But if you look at the two blue, 24% is probable and 40% is definite. Now, what do I mean by probable or definite? Probable, if you're talking to a neurologist, would be the ESC or the QSART. If you're talking to a clinician, it's that neurite density. So to be true small fiber neuropathy, that neurite density has to be less than the 5th percentile. But what if a patient comes in with an 8th percentile? What if they come in with an 11th? A lot of the time, clinicians will just group that together and they will move forward with treating them for small fiber neuropathy. And so I kind of broke out to the little side of the pink being epidermal skin biopsy being positive. So that's less than the 5th percentile. And the light blue is sweat glands, less than the 5th percentile. But if you wanted to approach it like a clinician, you would add the 24% and 40% for ME/CFS, and for long COVID, 22%, 51%. What that's getting here is 64% probable or positive for small fiber neuropathy and ME/CFS, and 73% in long COVID. Now, I wanted to see how this would relate to our iCPET. I'm always trying to bring it back to that. So what I did is I took negative, probable, definite by epidermal skin biopsy, and then definite by sweat gland biopsy to see if there's any significant correlations with our iCPET. Plot twist, there weren't at the current moment. We do have the constant thought, does structure equal function in this case? And so I'm going to focus more in here. I think there's a lot with just the phenotypes in the disease. But the last part that I want to get to before the end is the tilt table test. And I wanted to specifically focus on Dr. Peter Novak's tilt table test, just so that it would be consistent amongst all of them. So of the 420 ME/CFS with AFT, we got 157 and then 31 long COVIDs. This is where those are the iCPET and the tilt table test are two very, very common tests for ME/CFS patients in Boston. And I wanted to see if there's any correlations between the two tests. And what I found most interestingly, if you can think back to when I did ME/CFS versus long COVID versus controls, is that there was a greater change in heart rate from supine to 70 degrees upright to worse peak right atrial pressure, meaning dysautonomia caught on the tilt table test also correlated with the dysautonomia caught on our invasive CPET. And then finally, in conclusion, just to summarize, long COVID and ME/CFS perform similarly on iCPET, but they're significantly different than symptomatic controls. Dysautonomia doesn't only have to be captured by AFT, but can also be caught during our invasive CPET. And small fiber neuropathy is common in ME/CFS and long COVID, but its role in systemic vascular regulation and exercise intolerance warrants some further investigation, maybe find some biomarkers so that we can do targeted treatments. Thank you.
Very impressive. Thanks so much, Johanna. Now it's time to the next speaker, which is Massimo Nunes, coming from Stellenbosch in South Africa. He's going to make a speech on dysregulated coagulation system in ME/CFS. Thank you.
So, hello everyone. Just quickly on behalf of the South African cohort, the small group that we have, it's an honor to be here and thanks for the invitation. And I've been doing a lot of work this year on long COVID, diabetes, but I think it's really important to give attention to our previous ME/CFS work. And just to backtrack a couple years, Prof. Pretorius in 2020, 2021, she discovered these endogenous preformed fibrin aggregates that we call microclots in the blood of long COVID patients. For the last few years, we've done some extensive elaboration on these aggregates, if you will, and learned that they're a lot more complex. There's various phenotypes, but I'm going to leave that for Prof. Pretorius' talk tomorrow and not talk too much about them. So, 2021, patients actually prompted us to do similar investigations that we were doing on long COVID on ME/CFS. And we listened. We looked at the data. We saw that there's actually not many coagulation-focused studies in ME/CFS. And we know that it's not a primary pathology, but certainly dysregulation in the system might be relevant for symptoms, might be relevant for some kind of pathology. So it kind of warranted a modern investigation into coagulation into ME/CFS. So we recruited a control cohort, an ME/CFS cohort from the ME/CFS Foundation of South Africa. And just to take you through one of the techniques that might not be commonly known, it's thromboelastography. It's actually a bedside technique used in the hospital, in the clinic. It's to measure coagulation. And instead of measuring just certain factors within the cascade, this measures coagulation as a whole from start to finish. So it's quite comprehensive. And you don't have to know all the parameters, but there's some parameters related to kinetics and some related to clot size and clot strength. I'll take you through it. So we wanted to assess the whole blood against a clinical standard range that they use in the clinic. And for clotting kinetics, for 3 out of 5 parameters, more than 50% of the population fell out of standard range, all towards the hypercoagulable prothrombotic terminal. And again, the clot size and clot strength related to the maximum amplitude, that was also more than 50% of the population. So really, this is clinically significant data as it is already, and would likely prompt clinical response in the clinic, whether it's administration of, in this case, anticoagulant drugs, or if it was the other direction, obviously prothrombotic drugs, but that's not the case here. We assessed the platelet poor plasma against a control group, and we found significance for several parameters, but only really a real significance for 2 of the parameters, alpha angle and maximum rate to thrombus generation. And just a quick distinction between analyzing whole blood and platelet poor plasma is obviously the contribution of cellular fractions, platelets, red blood cells, and so on. We also assess platelets by microscopy. We use 2 markers particularly that can bind platelet activation markers, glycoprotein 2b3a and p-selectin, not that that's too important. And the image on the right, don't be deceived, we actually did not find too much platelet aggregation in the ME/CFS cohort. This is unlike what we see in long COVID, but we certainly did find activation, and we certainly know from previous research in the last 5 years, platelet dysregulation is certainly a component of subtypes or subgroups within ME/CFS cohorts. We also assess microclots, and we use a marker called thioflavin T, THT, that can bind these things and visualize them. Qualitatively, looking at these images, we can see that they are larger, we can see that they are numerous, but admittedly, this is not a quantitative technique, this is qualitative. And really what we wanted to do was get a quantitative grip on microclots. So we developed a cell-free method to image and analyze these things and quantify them. And in this particular assessment, we included a long COVID cohort, just for reference. And as expected, the long COVID cohort had a greater mean. The MECFS still had a very significant median compared to the controls. We also broke this up into various size ranges because just getting an average of microclots that are 1 micron squared all the way to 600 is not necessarily statistically interpretable or correct. And we can still see that the burden and the count was higher in each size range. Lastly, we did a mass spec analysis, a proteomics analysis, and we found some proteins related to the coagulation system that can really substantiate or give mechanistic insight into the previous findings with thromboelastography and microscopy. Platelet factor 4, for instance, on the right, that can explain or just corroborate the platelet dysregulation and activation that we saw. But protein S and thrombospondin coming from the endothelium, protein S is an endogenous anticoagulant. The reduction in this protein can certainly explain the increased clot kinetics, the increased clot load, and thrombospondin 2 also activates platelets. So we really got a nice network here explaining the previous findings. Also, we know that blood flow is significantly dysregulated in MECFS and long COVID too. Cerebral blood flow, there's a lot of perfusion deficits, and what we are interested is thrombospondin's perhaps mechanistic role in this regard, and we've been focusing in on that quite a lot, and hopefully we'll have some results in that early next year. What is important here is that we did not necessarily find a dysregulation in clotting factors per se, and as we know, this is not a primary coagulation disease, but likely just a byproduct of a dysregulated endothelium as shown here. We also found a downregulation of complement proteins, various markers related to 3 of the complement pathways, and some other proteins too, protein S100, pro-inflammatory protein. Hemopexin is a protein that scavenges heme from lyse red blood cells. And again, a lot of research recently is kind of showing that there's a lot of red blood cell dysfunction too and lysis. And ultimately, we showed some overlap between what we see in coagulation in long COVID and MECFS. But again, it's likely a result of this endothelial dysfunction. And if we look at research in the last 5 years and even beyond that, we know that endothelial dysfunction is a major component of post-viral disease, and it's been shown more and more, and mechanistically, we are starting to dive deeper into that. And I guess this is, I would consider an exciting field and something that I'm very interested in. And we think that the endothelium might be intimately involved with a lot of the symptoms and mechanisms too. And whether it's a primary defect in the endothelium or a loss of autonomic control or some neurovascular dysregulation, we still want to look at the vasculature itself and its ability to give rise to these symptoms and be central. And perhaps a lot of the tissue findings that we find in these diseases too could be secondary to some vascular disturbances or insufficiencies. I also do have a poster related to, I would say, more so coagulation, but using long COVID as a model. So please come see that too. Thank you.
Impressive. Thank you so much. Last but not least, I would like to present the next speaker, which is Gustavo Couto. He's a recent graduated medical doctor from Porto Medical School. He will speak about SARS-CoV-2 long-term impact on myocardial reverse remodeling. Thank you.
Hi, everyone. First of all, I would like to greet each one of you here today, and I would like also to express my sincere gratitude to Professor João Carlos Winck for giving me this opportunity to be here speaking about such an important end-year project of mine, which is the Long COVID project. This project has been conducted since 2022 in the Medical Research Center of the Faculty of Medicine of University of Porto by the MyoCare group, which is led by Professor Inês Falcão Pires. I initially joined MyoCare about 2 years ago in order for me to develop my master thesis in medicine. And so today I'm here to talk about it. Since the beginning of the pandemic, the MyoCare group rapidly identified not only a huge gap in terms of clinical and scientific knowledge, but most of all, they identified an opportunity for them to further explore the scope of their investigation. They are mainly concerned about the cardiovascular physiology and pathophysiology in multiple conditions. It became quite clear since an early stage that COVID-19 was associated with a significant acute impact on the cardiovascular system, with multiple forms of cardiac involvement being described in the literature. Beyond this short-term and acute impact, there's now growing evidence that suggests a persistent cardiac dysfunction among survivors of SARS-CoV-2 infection, namely through an increased long-term risk for cardiovascular disease, and also through imagological and analytical abnormalities among these patients. We all know what is the definition of long COVID, so I'll skip this slide. What you may not know is that cardiovascular manifestations represent the third most frequent category of
Será que não está ninguém daqui que possa lhe dar uma ajuda? Isto é o...
Não.
Ficou aquele primeiro slide. Espera aí. Ok, já está.
Sorry about that. As I was saying, what you may not know is that cardiovascular manifestations represent the third most frequent category of long COVID symptoms, surpassed only in frequency by the neurologic and neuropsychiatric symptoms and by the respiratory symptoms. Considering this long-term impact of the COVID-19 on the cardiovascular system, a big focus of long COVID was to investigate the potential impact of SARS-CoV-2 infection on the surgical outcomes of patients with aortic valve stenosis. Likewise, we conducted a multicentric observational study, including patients with a diagnosis of moderate to severe aortic stenosis, according to the European Society of Cardiology guidelines, that were referred for aortic valve replacement surgery at one of two different centers, at Unidade Local de Saúde de São João or at Hospital de Santa Cruz, which currently is part of the Unidade Local de Saúde de Lisboa Ocidental. You may be wondering why we restricted our population to the patients that had a pre-established diagnosis of aortic valve disease. And the reason why we did this is because one of the main goals of our study was to establish in detail the myocardial histology, as well as the molecular processes that may be underlying this long-term cardiovascular involvement in survivors of SARS-CoV-2 infection. And so it was really mandatory for us to have the potential for obtaining myocardial biopsy specimens through myocardial surgery. At Unidade Local de Saúde de São João, patients were recruited on the day of their respective hospital admission, and they were given a detailed questionnaire which allowed their allocation into one of three different groups: the group of patients with no history of previous SARS-CoV-2 infection, the group of patients with a previous history of SARS-CoV-2 infection that was followed by complete symptomatic resolution, and finally, the group of patients that fulfilled the criteria for long COVID. At the time of their hospital recruitment, each patient had already undergone an echocardiogram, and a new echocardiogram was performed 3 to 6 months after surgery. In terms of the patients recruited at Hospital de Santa Cruz, the protocol was quite similar. The patients were again given a questionnaire that allowed their allocation into one of the three pre-specified groups. And then we rearranged all the data into a new database and performed the statistical analysis. We first investigated for differences between the three groups, the no COVID, acute COVID, and long COVID groups. And additionally, for the echocardiographic variables, we also tested for differences among between the 2 time points, before surgery and 3 to 6 months after that. The results that I am presenting here today concern a total of 96 patients, of which 13 had a history of SARS-CoV-2 infection that was followed by complete resolution, and 7 of which had an established diagnosis of long COVID. Albeit these numbers are admittedly small, I would like you to view these results as a preliminary insight, almost as a first look into what this study may reveal in the near future. As you may know, aortic stenosis is a prevalent condition that exposes the left heart to an increased afterload. And as a result of this valvular dysfunction, the heart undergoes a maladaptive process of cardiac remodeling that is essentially characterized by a concentric hypertrophy of the left ventricle. It is expected that after AVR, a process of reverse remodeling occurs in which the heart regains its initial form. This is called a process of cardiac reverse remodeling. Our results are consistent in identifying a benefit of the surgery in terms of the transvalvular aortic gradients. And overall, our results also show a significant reduction in terms of left ventricular mass, as well as relative wall thickness, which are considered 2 hallmarks of left ventricular hypertrophy. However, although this reduction retains its statistical significance when the group of patients with no history of infection is considered separately, the reduction is no longer significant in the group of patients with a previous history of SARS-CoV-2 infection, whether followed by complete resolution or evolving into overt long COVID. Albeit this population was really small, I think we can all agree that this study highlights the need to establish objective criteria to accurately identify patients that may be suffering from chronically sustained long-term cardiovascular compromise through an history of SARS-CoV-2 infection. The fact is that we found out that a lot of patients that had a previous history of SARS-CoV-2 infection may be less prone to responding to the reverse remodeling of the heart that is expected after surgery. And so I think this really is a glimpse of what we might get in the near future about these studies. And I would like to thank everyone who has contributed to this study, more directly or indirectly. And I would like to thank everyone for your attention.
Thank you so much, Gustavo. I'm sure that Dr. Systrom's group would love to have iCPET on these patients before surgery, right? But I think we have time for a couple of questions. I know that we are like 10 minutes delay, and our fantastic host, Joan, will lead the next panel. So I'm sure that she will say that we can have some time for questions. Yeah? Is there any question? Oh, yeah, a couple of questions. Go ahead. Introduce yourselves.
Rob Husti from Amsterdam. Gustavo, very nice work on the heart samples. Are you planning to do any other measurements on these heart samples?
Sorry, I didn't.
So you collected samples, right, from the aortic?
Oh, yes, we collected samples from the patients that were recruited at Hospital de São João. Of course, we did not do it in all the patients because there were concerns about the surgical feasibility of this collection. And so the collection of the samples were only performed when there was like a clinical possibility to do so. The patients recruited at Hospital de Santa Cruz, those ones did not give us material, biopsy material, because they were included in a previous study. And so there was more like of a retrospective study in nature. But
so your long because the most interesting samples, of course, are the long COVID samples.
yes.
So I spotted on your slide that you only had 7 people included in your slide. Were you able to get any samples from those people?
Sorry, I did not.
There were only 7 people. On the
7
long COVID,
people, yes.
But did you get any like samples, like tissue samples from those people?
Yes, we did. We have some preliminary results.
Cool.
The one that stood out the most for us was really the cardiac fibrosis. We had some insights about also the pericardium and the pericardial fluid, but the cytokine profile of the fluid was significantly different between patients with long COVID and patients with just a history of fully resolved infection. But I have to say that the results of the pericardial fluid were really difficult for us to interpret in terms of our theoretical knowledge. But the ones that really stood out were the histology of the myocardium, which revealed a significantly amount of fibrosis, and we were not expecting such a huge finding.
Thank you all very much for the beautiful presentations. I also have a follow-up for Gustavo. Really super interesting work with the cardiac tissue. I guess this is maybe 2 questions. I might have misheard, but you saw a decrease in ventricular mass with the long COVID patients, but I think you followed that up by saying that you also saw consistencies with left ventricular hypertrophy. Can you maybe elaborate or clarify that point? Because in my head, the hypertrophy should then go with an increase in mass.
So when we have an aortic stenosis, the heart usually responds by increasing the left ventricular mass, that is the ventricular hypertrophy. But when the patients are surgically interventioned, the valvular function is back to its original form. So the afterload is relieved. And what we expect after the surgery is that the heart reverses the process of the cardiac remodeling. So the hypertrophy is no longer detected, or at least it is partially normalized back to its original form. What we found out was that in the group of patients with no history of infection, there was a significant reduction in the left ventricular mass, which was what we expected to occur. But in the other 2 groups, which were the ones who had a previous history of SARS-CoV-2 infection, whether it was followed by a complete symptomatic resolution or by overt long COVID, there was no significant reduction. So the patients retained higher levels of ventricular hypertrophy, even though they had the same alleviation in the afterload.
Okay, awesome, that's clear. And could I do one follow-up? Was this also accompanied by a decrease in distensibility of the cardiac tissue in any way in either the ventricles or the atria?
Well, we investigated different types of echocardiographic parameters. The ones that I brought here today were the ones about the morphological parameters of the myocardium, but we also investigated the diastolic function parameters, E and E prime, and its ratio. And we also performed analysis in terms of left ventricular ejection fraction, in terms of the systolic function. But the results were not quite understandable. There were no significant reductions. And the reason I think this happened because we are dealing here with aortic stenosis patients, and the only thing that is actually really established to occur after the surgery is the reversion of the left ventricular hypertrophy. Even in controls, we do not seem to observe every time an increase or a decrease in left ventricular ejection fraction, as you would predict. I think it is a little, your intuition says that the ejection fraction is going to be improved in normal patients, but this is actually sometimes not the case, even among controls. So we did not find any statistical significant results. That's why I didn't bring them today.
Last question.
Yeah, great panel. Thank you all for your presentations. Actually, my question is not to João, because he was my former PhD student. It's actually to Massimo. If I understood correctly, you said the coagulation system is affected, but it was supposed to be like downstream effect, not like. Did you try to correlate that with disease duration if you had that information in your patients?
Yes, we definitely did. And if there was a good correlation, I certainly would have presented it. We did not get many correlations. I would say the highest we got is a R-squared of 0.7 for some of the TG parameters and few of the symptoms. And if I remember correctly, it's neurological. So certainly we would require a more in-depth study, better design study perhaps, and hopefully we'll see a correlation there. But again, the coagulation system is something that's very easily influenced by pathology in various other systems. And we know the endothelium is so tightly regulated and it tightly regulates coagulation. So I think minor dysfunctions in there would show dysfunction in the coagulation system. Perhaps if we redesign the study and focus more on endothelial markers and endothelial dysfunction and correlated that to symptoms, I would suspect we would have got a much better correlation.
I was just wondering if actually you could have done like some kind of like a regression analysis where actually include all these type of features, and
Yes.
then you try to explain the effect of age, effect of disease duration, even on severity.
Yes.
That will give you a more broad picture of your finding. Yeah, thank you very much. It was very interesting.
Thank you.
Okay, thank you all. Very good.
One question for Johanna, please. That won't? So, Johanna, you are involved in Young Emerge, and I believe some of you. Are you here? Okay, so the question's for Johanna. Johanna, I know you are an active participant in Young Emerge. I don't know, Massimo, João, and Gustavo, you need to join. Could you tell us a little bit about this initiative? And also, congratulations. This is not a secret. This is my favorite panel because it is, because really you represent emerging areas of new energy and the future of the work. So thank you. So you could do a little pitch, please.
Yeah, of course. So some of you might be familiar with eMERGE, which is the European Coalition for ME Researchers. The youngins decided to make their own group, so Young Emerge. It's not just limited to Europeans. I somehow snuck in. But what it is we meet, discuss journals. We even have our own kind of mini symposiums before big conferences such as this. We encourage all levels of research. So I don't yet have my PhD, but I can actively participate in the different activities. I know they're going to Vienna this month, Anouk, are they? Yeah, okay. And doing, basically, they fund some scholarships of exchanging to go to Vienna or for the Austrian students to go elsewhere. So it's almost its own fundraising. It's a way to network. It's a great way just to connect so that the young researchers can hope to fill the shoes of our PIs.
Can I ask one small question for Massimo and Johanna? When we don't still want to invasive CPET in Portugal, I'm correct? When you're doing it in the States, do you also do blood work, and does the blood work include coagulation samples, and would those coagulation samples help Massimo in expanding his research?
I actually think that both of our PIs were talking about that last night. So yes, we do minute by minute blood sampling. Sometimes it's every 2 minutes, but we definitely catch resting, peak, and then an hour post if they consent to give just keeping the lines in for that time. But we are working on a material transfer agreement right now because we're sitting on a whole biobank of samples. So it'd be nice to send them over.
So
No, send samples to you as well, because that will expand your
okay, so okay, thank you so much. fantastic job you've done. Your early career will be fantastic for the future, I'm sure, for ME research. So thank you again for your talks. And let's hand over to Professor Vaz Carneiro.